Hi, everyone. I'm Robin Shapiro. I'm the board chair emerita of Health Advocate X, and you've caught us at another community conversation. Today, we're going to be talking about all things COVID 4 years in. We have Dr. Dale Reisner with us. But before we go ahead and start, I'd like to just establish this meeting as a safe place. And what that means is that we all come to this meeting with different lived experiences. And we want to make sure that everyone is heard and respected. And because we all come from different backgrounds and lived experiences, we understand that there's a potential for harm. And we as a community and as an organization are committed to healing should harm occur. I'd also like to just say that I'm speaking today from Qualicum Beach, BC, Canada. And that is part of the unceded land of the Comox people. And I'd like to acknowledge the Comox people and their community and pay my respects to their past, present, and future elders. And I encourage you to think about the land in which you are on today and also pay your respects silently. And with that, I would like to turn it over to Dr. Dale Reisner, who has been a wonderful board member for Health Advocate X and was the former medical director of quality and safety at Swedish Health Services. So, Dale, take it away.
Hi, and hi, everybody. Glad to be back with this group for a little catch up on some of the things we've talked about over the past 3 to 4 years. I do want to start with just some very maybe less than rewarding updates on public health. Because public health really is the core and the base, and is kind of quieter than it should be, in that most individuals, when they go to get a vaccination or they go to the pharmacy or they go to their provider's office, well, don't think about public health. But public health is there with in ensuring safety, and has many areas of interest that affect our health that might not be obvious, when you're at a doctor visit. So one is climate change. Climate change, the weather extremes in particular, we will be heading into some heat, and we still see some freezing temperatures. And so all extremes affect health, overall health, as well as we always see increased death rates, from whether it's from too cold and somebody doesn't understand and burns something that has carbon monoxide inside their house, or whether it's too hot and people can't get away from that and die from heat, direct heat, or dehydration. And then sort of secondarily, as climate change is happening and places are warmer than they used to be, we're seeing increased mosquito and tick-borne diseases. Obviously, you will be caring for some people as a health advocate, or if you're part of an organization that have these illnesses, because many of them turn into chronic autoimmune-like illnesses. So that's one area that they are always looking at. The solar eclipse is something you probably are hearing about, and that's a public health concern because there's so many people that don't understand the potential damage to the permanent damage to the retina from looking directly at the sun with the solar eclipse. Or even directly at the sun without protection in general can have some impacts on your retina. So that's one that might not have been in mind. Health equity, of course, is part of Health Advocate X's mission and values, and is core to what public health does, including things like access. That's not just do you have health insurance, but can you actually physically get to your provider's office or clinic, the social determinants of health that have to do with clean water, adequate living conditions, so on, and the differences in outcomes. And then vaccines, and you'll hear more about vaccines for sure, about public health. And it's usually county-based, so it looks really different from county to county, from state to state. But helping to get vaccinations out to the public is a big core mission for public health. So if you ever see anything that asks for support of public health, please consider donating your time, donating your dollars, donating your voice if it has to do with legislation, to support the strong work that these folks do.
Thanks, Dale.
Yeah. So, yeah, not data in that, but just a reminder. So, and then we're going to do, like, you'd think we're tired of COVID, but
4 years.
I certainly was tired of COVID, but actually it is good to update ourselves, because things are changing. And so I've kind of divvied it up into some different sections, and we can take questions as we go along. Robin, as the usual great moderator that she is, will help us do that, or interject her own. And then I'm going to break it out a little bit. It's all under the auspices of what we know now, that we didn't know 4 years ago, or that we didn't know even 2 years ago. And so we'll start with what the CDC has said very recently about a unified approach. And I like this in some respects, and I don't like it in others. And I will throw in, I will tell you always where my source is and what they're saying. And I will also tell you when I have a comment to make. So what they're opting for, and this makes sense, is a unified approach to simplify their recommendations and to look at it for more than just COVID. So all of the viruses that we see that are seasonal, these recommendations that we've had for masking, isolation, et cetera, they should apply to all of those things. I think we were pretty cavalier about the common cold in the past and would go places freely, and we weren't wearing masks for sure in this country. But in fact, there are vulnerable people around us when we go outside of our homes, or we go visit our elderly relatives or people with immune disorders. And so we really want more of a pan-respiratory approach. And I think that you can look at a manual transmission too. So a lot of the gastrointestinal disorders that are infectious can be from not washing hands. Respiratory, of course, can be carried that way as well, but mostly is aerosol. So the things that the CDC said very recently in March, testing at home is optional. If you are high risk and want to test, just know that a positive result is very much likely a positive result. Even if it's that faint little pink line, that's positive. So the positive predictive value of our home testing is excellent. The negative predictive value is not so much. So you can have COVID and have negative test results, especially if you have a mild disease, but even otherwise. And it appears that if you test early, and this applies to times where you might have been exposed to someone, don't run home and test day one or day zero, but wait for 2 or 3 days if you're not symptomatic. And if you are symptomatic and you feel like you'd like to test right away, you might be thinking, well, I need to get a hold of my doctor and get some Paxlovid, or I was planning a big thing and do I need to cancel, whatever. Then make sure that you test like 3 days later, 5 days later. So that really has clarified, we've gone from no testing available at all unless you had a fever, were traveling in China and had a cough. Then we had home tests. We had tests at the hospital, then we had home tests, and now home tests are around. Many people are not using them. So it's fine if they choose to not. However, I personally feel, I think here's my personal comment, is that they are then not necessarily taking responsibility for getting somebody else exposed who could have very severe illness. So I think that is the way I live my life.
I think that's
Yeah,
the big piece of that is not just for yourself, but also for others.
yeah, yeah,
Because we are mixing and mingling
a
out
lot.
in the world a lot more. And so
Yeah,
if you don't know if you have COVID, that might change your
right, right,
actions. Yeah.
right. Yeah.
Mhm.
And we don't hear it in the news, but I still hear anecdotally about super spreader types events like weddings and parties and things like that, where, a chunk of people come away with the disease. One of the things that is on everybody's mind, either for as a pro or a negative, is masking. And so their recommendation from the CDC was, once you're diagnosed, you should be masking um, if you go out, or if you're around other people. And you can, if you have a positive COVID test, masking when you go out in public for 5 days after you stop your isolation. So your isolation is, they're not designating a finite period of time for isolation. It should be that you no longer have, that you isolate until you no longer have a fever without taking Tylenol or ibuprofen or something else to bring the fever down, and your symptoms should be improving. So many people don't get a fever, and so symptoms should be improving for those folks. If you have a fever, it should be gone without having to do something to try to get rid of it. And then if you go out in public, mask for 5 days. So you no longer need to isolate for 10 days automatically. We know that some of this kind of relaxing the recommendations is going to mean that there'll be people out with the tail end of COVID still having virus in their system, maybe not as infectious as what they were to begin with. And so, again, we come back to, if you're going out in public, do you want to just put a mask on and, do good hand washing? The part of the rationale for backing off on all of the recommendations is so many people weren't doing what was recommended anyway, and we're trying to come up with a constellation of key things for any type of infectious viral respiratory disease that people might do. So that was,
It's almost like new norms. Like,
yes,
you know what I mean? It was
yes.
interesting. I think I mentioned this. My husband and I went over to a neighbor's a couple weeks ago and walked in, and she was sick. I mean, she had a cold, and I was like, "Oh, you're sick." And and she said, "Oh yeah, I just got this from the grandkids, no big deal," kind of thing. And I was thinking, "Oh, well, I would have expected, and I think our society is changing a little bit around norms around informing people about when you're sick or, that kind of thing, so that
Yeah,
people can make their own choice about whether or not they want to be exposed."
yeah.
So,
And you're exactly right. A lot of people are trying to normalize that. And remember, every disease you get from your kids is not necessarily something that's good for you as you age, or if you have some type of yeah. Did you leave? Is in the chat.
did you leave? No, I didn't. And actually, I ended up getting sick. I washed.
Hmm.
I didn't have a mask with me. I wasn't expecting that.
Yeah,
And I ended up getting sick because
yeah,
I'm more prone to those kinds of things.
yeah,
It's
yeah,
disappointing. And it was just a cold. Thank goodness. So,
yeah, yeah,
yeah.
yeah. But sometimes it's not. Like sometimes it's RSV, which we know can
Yeah.
get us much sicker as we age. So yeah, and I have a 2-year-old granddaughter, so I have to be a little bit careful
Mm-hmm. Mm-hmm.
around that little, what we call a vector, a little vector carrier of diseases.
Well,
Um,
and I guess, I mean, it just brings up one other thing that I just want to comment on
mhm.
from a health advocacy perspective. I guess as we enter into a little more virus maybe season, maybe a good, maybe a good cultural thing is just to say, and if you're happy, if you happen to have a cold or anything, I'd love to know before I come
Yeah,
over. I would not never have thought of that, but maybe if
yeah.
we're, we have differing levels of risk and comfort, that might be a way to address that
I
as
think
well.
that's super important, and to have respectful, just because they're not as worried about it as we might be, that doesn't
Yeah.
mean they're bad people.
Right. Oh, no. I
Yeah,
love I
yeah.
love our neighbors.
That,
They're awesome. Yeah.
my family knows that I get hit hard when I get
Mhm.
those things, and so they're pretty good about letting me know, but not always. So yeah. The one other thing I was going to mention, you may have seen this if you've gone into the drugstore, if you are picking up some meds or something like that. But if you're over, so all along, the CDC has said if you're immunosuppressed, you can get frequent immunizations for COVID, because we know that the body's response is not as robust for many people who are immunosuppressed. It depends, of course, on the individual and also what they're immunosuppressed with. I mean, if you're on chemotherapy, that's a dramatic degree of downregulating your immune system. And you may have an autoimmune disorder that doesn't have as big an effect. So, as an individual, figure it out, kind of thing, for what works for you, what your preferences are, and then more recently, I think it was February or early March, the CDC said that it was fine for anyone over 65 to get an additional dose of the vaccine at this point in time. So, half a year from basically from when you might have gotten it in the fall, just
So,
because.
so do we know, like, say, somebody who has had all of their vaccinations versus somebody who's had periodic vaccinations versus
Mhm.
somebody who's had no vaccinations and then do we know what the difference in risk in getting long COVID or hospitalization is? Like, did all those previous vaccinations that we've been getting all along mean nothing in terms of when we're facing a different, iteration of the virus?
I'm going to answer that in a nanosecond.
Okay.
What I did want to say, just as a tag on the 65 or older, is when you look at last year's hospitalizations and deaths, from COVID, most of those occurred in that age group.
Mhm.
So that's partly why they came out with this, authorization of a second dose. Beth, you
Yeah.
look like you got a question. Yeah, or a
And
comment.
I have a question, just because a lot of the folks on the call probably are dealing with going into healthcare institutions. So even though the CDC has relaxed what
Yes.
they say, each institution can set its own standards, right? Like
For
I'm
sure.
finding here in Wyoming, it's way more conservative. When I go back to Seattle, nobody's masking in hospitals. And here they are. It's up to each individual hospital, right? Like,
So, and I would have expected in the Wild West of Wyoming
I
that they
know.
wouldn't be masking. So
Well, I'm in Jackson.
awesome.
It's a blue portion of
Oh, you're in the blue part. Okay. um, so yes, and that I was going to mention that, and Robin, I'm not forgetting your question, but uh, each healthcare institution has their own masking versus not masking. They should be letting you know, and they should be providing masks and gel for you on entry if they have masking for all patients. Um, what I've noticed is that many places, the healthcare workers are masking themselves, but not necessarily requiring masking of the people who come in. And there are other places where they're asking them. So that's going to depend, I think, in part on rates of infection, any type of infection. And I think we'll see this more generalized too, flu season, et cetera. But yes, the majority of hospitals will have some masking practices still in place. And don't be thinking that just because you walk into a place and all the staff are masked, that they're having a horrible outbreak of COVID. That's not the case. They're trying to protect themselves. And we'll talk a minute about that at the very end. I have a few comments about healthcare staffing and providers. Yeah. So I am going to talk a little bit about myths about COVID, and this feeds right into Robin's question. I think she was a purposeful plant with that one. I don't know, but so that that really the question I think you're asking, Robin, is we were expecting to get herd immunity from COVID, and yes and no is the answer to whether we have that or not. What we will continue to see is lower. We have much lower rates of infection. Looking at wastewater, which is the only way we really can track it right now, because people are not reporting positive COVID tests to the CDC anymore, or very rarely, and so similar to the flu, we'll continue to see probably more seasonal variations, and not because the virus isn't around so much, but because the winter time, the fall and the winter is when everybody, kids are back in school and we're all indoors, and we've moved from the family vacations of the summer, where we're not in huge collections of either business meetings or business environments. So what we've seen now is the majority of the cases are milder. So excuse me, have we got some degree of carryover from these vaccinations? I think the answer is yes. Does the vaccination that you got in the fall protect you year round? Probably not. So I think that's why people are now looking at, excuse me, I have a tickle, looking at higher risk people being given potential additional vaccinations. But the data is, if you compare, excuse me, just a sec.
Yeah, no problem. So this is a good time to just say, if you have any questions, please put them in the chat and we'll go ahead and be teeing them up. So, Dale is about to kind of just focus in on some myths. And if there are any that you would like her to specifically address, now's a good time to put those in the chat. So thank you. And thanks everybody for your patience here.
Yeah, when we were prepping for this, we were talking about some of the myths, and one of the problems is it's still nascent data, so we still don't have really strong answers to a lot of the myths that were there. But let's let Dale tell us more.
Yeah. So I have this little tickle that comes and goes. That came from the last time I had COVID, and doesn't ever go away. Every once in a while, something will tickle my throat. So I apologize. Yeah, if you compare vaccinated people versus not, any degree of vaccination, there seems to be milder disease. The vaccinations were always meant to prevent death and severe infection. And that's where I think people get a little bit confused, because yes, you have lower cases if you're vaccinated, especially if you're freshly vaccinated. It can prevent some cases, but that was not their primary goal. That would be what we would call maybe a secondary outcome. Primary goal is to keep people out of the hospital so that the illness
and alive.
That's right. And in doing that, far less likely to have severe long-term complications. We'll talk about long COVID by itself because that is a different animal. But just think about, compare it more to the flu and the common cold. It's more in that virus category anyway, in that family. It's not like measles or smallpox or polio where we've actually been able to come pretty close to eradicating. When I say pretty close, we really thought we had eradicated smallpox, but then we started seeing that globally a little bit pop up again. So, and if you're not actively surveying, which is a really important thing that public health does, then it can get carried away. And then we've had so much anti-vaccination around certain vaccines, for instance, measles, that we've had big outbreaks of in pockets around the country of measles, which were rare for a while. So a little bit different type of virus. The other thing, and this really speaks to this, what I've already mentioned, is that you are less likely to die from COVID and no more likely to die from any other disease if you're vaccinated.
So can you say that again?
You're less likely to die from COVID, and in conjunction, you are no more likely to die from something else if you had COVID vaccinations.
So it's not increasing your
It is not
risk.
increasing of
That
other
is an
cardiovascular
important-
death or whatever. And I'll talk about, I'm going to mention some specific things that we've heard about over the years.
So that seems in the myth category.
Right.
Yeah.
So there is a viral syndrome called Guillain-Barré. It affects the nervous system. That did have a higher incidence specific to Johnson & Johnson vaccinations. Johnson & Johnson vaccinations are no longer available in the United States. They are being given globally, but no longer available.
Because of side effects or increased risk? Okay.
Yeah, because of increased risk.
Got it. Because we have
Remember
somebody
Johnson-
in the chat that said, I know someone who's an anti-vaxxer, claims to know a man in his 60s who had a stroke after the vaccine and a young man in his 20s who died shortly after being vaccinated. And
Yep.
I even heard of the Chinese vaccine actually causing death in certain people who took it. So, but
Yep. So this is why I thought it was really important to call out some of these. And actually, I'm going to mention probably each one of those examples. So if you look at the two other more common concerns that came out of vaccinations, thrombosis, so stroke, right, or other types of blood clots, the incidence was with Johnson & Johnson vaccine, there were 4 cases per million vaccinations. 4 per million.
4 cases of
Thrombosis
thrombosis
that were
okay.
clearly attributable to somebody recently being vaccinated.
Okay.
It was Johnson & Johnson vaccine.
Which is no longer available
in our country.
in our country. Okay.
It's
Okay.
also not that many.
Not that many in the first place.
Yeah.
Obviously,
they
these
took it
things
off
are
the market,
serious
so,
and you're going to
yeah.
hear about them, right?
Yeah. Yeah.
So what you don't hear about when you hear about somebody, the relative of somebody or whatever, of course, that personalizes it.
Yeah.
There was a teacher, I think, or maybe she was a educator by training, and she was a stay-at-home mom, wanted to go help in school in Washington State, who had a Johnson & Johnson vaccination, which at that time, we were already cautioning women of reproductive age not to get it, but she did because she wanted to be in school with her kids. And she had a thrombotic event and died. So we hear about those things. They break our heart. But we're not comparing that to how many deaths have been prevented overall. So that's the hard part, right? So the
Yeah.
population versus the individual. And if
Right.
you don't have the population data to know, like with everything you do, when you walk out the door and get in your car, you're taking a risk of death. More
Yeah.
so than having a vaccination, let me just tell you. So myocarditis is the other one. So that's probably the younger person. That was not with Johnson & Johnson. It was with the mRNA virus vaccination. Very rare. They don't actually even have great numbers to compare. The cases were primarily in young males, teenage to early 20s. So rare enough to probably be in that same, low number of cases per million type of data. And real. They were, I think every case reported was after the second dose of an mRNA vaccination. So those are the facts. And I think everybody has to make their own decisions. So when I say anti-vaxxers, I'm not saying it to be mean or anything like that. There are people that are pro and people that are against. And so they take their chances by not vaccinating. The only thing they have to remember, I think, from a personal perspective, is that if they're not vaccinating and they get sick, then they should be isolating the way the recommendations go, and they should be masking, and they should be making sure that they're not infecting other people. Because when you go out,
vulnerable. Yeah.
right, when you go out in society, all of a sudden your individual choice has an impact on everybody else. So whether you vaccinate or not. And then the other thing that kind of falls into the myth category is Paxlovid. So Paxlovid has great data showing decreased severity of illness, decreased hospitalizations, decreased death. There was some suggestion of decreased risk of long COVID, and if there's an impact there, it's probably small, but it would be a positive impact, i.e., not increasing long COVID, but possibly a small decrease in long COVID risk. What we do know is the more times you get COVID, you're not necessarily protected against long COVID. So long COVID can come with any one episode of COVID. And just because you had it 3 times before and didn't have long COVID doesn't mean you couldn't get it. What we are seeing, and I'll talk, as I said, I'll talk about long COVID as a separate topic, I guess, is that the risks are varied in different age groups, and I'll give you some little bit of information about that. What Paxlovid does, again, is decrease hospitalizations, ICU admissions, and death in people that are at high risk.
And what it does from like why you should take it, speaking from personal experience, is that if you're really sick, it decreases shedding of the virus, right? That's like the basic thing.
It decreases it. What it does is it
the replication of the virus.
It has an effect on the replication of the virus, and the effect on you is to decrease your immune response to that sort of ongoing, out of control virus.
Yeah.
People have talked a lot about rebound. There are 7 studies. Only one of them was a randomized controlled trial. 4 of the 7, including the one that was a randomized controlled trial, showed no significant difference between the rates of rebound for unvaccinated with COVID and COVID with Paxlovid. Okay. The rates were in the range of 4.5% to 6.5% of rebound. So if you got rebound,
seems like it's higher based on what you hear out there.
I know it does, but this is population data. So
I know.
right,
so myth
right.
versus reality.
That's, well, no, I mean, the reality is maybe everybody you know, or a lot of people you know are high enough risk that took it in the first place. And,
Mhm.
you know, that you have a collection of people that's a, you know, a unique group. And that's what you're hearing. And so that is always why our personal experience is important. We want to put it in context of what else we know. So there's does not seem to be an obvious increase. And the only one study where there was even what you would notice as a difference was 4.5 in one group and 6.5 in another. So a 2% difference, not like a 10% difference, which people were talking about maybe 20% risk of rebound. None of this seems to have a 20% rebound. So
Yeah.
Yeah.
Good.
okay. Any other questions
So
about
we do,
myths?
yeah,
Mhm.
we do have some questions, so we can take those right now.
Yeah.
One is so you're gonna address long COVID next,
Mhm.
right? So,
Yes.
we'll hold that one, which was a question about updates on treatments for long COVID, so you'll address that next. Will you address the issue with the pulse oximeter and its inaccuracy for people of color, which I never knew that. Have you heard that? It's from Tracy Plunkett. Thank you, Tracy.
Well, it, I haven't specifically heard that, but it makes sense. I mean, it's a cutaneous monitor, and those things can be affected by color.
Yeah. Yeah.
Yeah.
If you don't mind, I mean,
Yeah, please.
because a lot of people don't know about it, even
Mhm.
doctors' offices, right? So, so basically, the pulse oximeter, well, the FDA did a warning back in, I think, 2021, might have been 20. And it was also in the New England Journal of Medicine that the pulse oximeter is not accurate for people of color because the light hits the melanin first, so that reads it. So their pulse scores, oxidation scores were showing higher than they actually were. So people were being sent home where their scores probably were a lot lower.
Right.
Now, I am still finding, and every time I go get the doctor or go to the doctor, folks are still using it. So I think there's still not a lot of awareness out there, but I was wondering if you had heard that. So
Yeah.
that is
I'm not at all surprised. And don't it's anything that's color. So
yeah.
I'll give you a very quick anecdote. We used to do for preterm birth, if we weren't sure if somebody was leaking fluid, we used to put a dye in the amniotic sac if we were checking for infection and so on. And so somebody used not a toxic dye, but not our usual dye. And this baby was born a day later and was bright blue. And they could not use any of the cutaneous monitors on that little character till the blue wore off. So
Mhm.
so yeah, it's any color, and people should have really thought about that a long time ago, honestly. But
So good information.
we don't have, we
Yeah.
don't have a good alternative to that, right?
Yeah.
Yeah, well, there is I'm obviously researching
Mhm.
because
Yeah.
it's dear to me being of color,
Mhm.
but in general with there is a company, I think they're called Massimo. I'll see if I can find it. They're supposedly created something that reads various hues of people that's supposed to be accurate. I think people can buy it themselves. Of course, it's not out there. It needs to be in the doctor's
Mhm.
office, the hospitals, to be honest. So I don't think it's out there yet, but yeah, but it's interesting. Even every time I go in, I'm like, it probably may not be accurate for me. I'm just saying.
Yeah.
Exactly.
Yeah, just
Thank
saying.
you.
Yeah.
Thank you for
Thanks for
sharing
bringing that
that,
up. Yeah.
Tracy.
Yeah.
Absolutely.
So-
Thank you, guys.
Sure.
Okay, let's see. I
So,
have another, let's see. This is from Adrian Miller, when COVID started, those of us who work with vulnerable populations could get vaccinated even if we weren't in the current demographic listed as eligible. With the new recommendations of 65 plus getting another vaccine, should those under that age who work with vulnerable clients be getting a booster?
That I don't know the answer to. And I don't know, I don't know if a pharmacy would give it to you without, I mean, I would query
Yeah.
the CDC directly probably and say, is there a way? I would
So it
think
seems
that,
like when you go to get a booster, they're not screening anyone out. Like if you want it, pharmacies seem to
well,
be
it's
giving
not
it.
considered a booster now, right? So
Yeah.
it's a vaccine and I don't know if they would screen it. You may not have your insurance cover it.
Hmm.
You may be paying full price for it. And it seems like if you say you work with somebody that's at risk, that you feel like you need to have that extra protection, that they should give it to you, but it might not be covered by your insurance.
Okay, let's move on to long
Sure.
COVID, please.
Sure. So let's talk about long COVID. There was a study done in 2022 but it was a survey done by the CDC, and there were almost 7 million people, adults, who were surveyed and had self-reported long COVID. So 3.5%, about half of them at the time of the survey actually had it, and the others had it and it had resolved. What appeared in that study was the age group that was most affected in adults was 35 to 49-year-olds. They had almost a 9% ever having long COVID, and at the time of the survey, 4.7% still had it. And then the group of children was 1.3% who ever had it, and about 0.5% who had it at the time. So the kids seem to be able to shed it a little bit more quickly than the adults. And the highest group of children were teens who were like double all of the other age groups. And this is probably makes sense because we started hearing about long COVID in, young gymnasts and people like that, where that was publicized. So all of these, and I don't have the percentages in front of me, but women are more affected than men. That fits with all kinds of autoimmune conditions to be much more prevalent in women than men. And then the symptoms are different. So what I thought was really interesting and obviously very sad for kids is that headache, loss of smell and taste, brain fog, and pain were the most common symptoms. So you can imagine if they've lost their sense of taste and smell and you're a toddler, how hard it would be to get them to eat and to get them to focus and all of those things. So that, it's a challenge for parents of young folks who have it. And the other thing that was seen, and actually this doesn't surprise me that much, although more in children, was an increased risk of type 1 diabetes. So we've known for a long time that type 1 diabetes probably is a genetic tendency that people have, and then the trigger for the disease to emerge has been some sort of viral event. So that doesn't surprise me as much, but that's the best sense we have of overall risk of long COVID or rates of long COVID. Not so much risk. Prevalence of long COVID, not so much risk of long COVID. And I don't think anybody will better be able to tell, I think, moving ahead. But for so long, people were complaining about long COVID symptoms, and there was no way to collect who had it and who didn't. And it even took a couple of years for a real diagnosis, because COVID itself can take up to 3 months to go away. And so going beyond 3 months seems to have been the more typical definition for long COVID. So I think that we'll have a better idea of actual prevalence of long COVID after a COVID episode when we have a few more years behind us. There's an NIH study that looked at adults and listed the 12 most common symptoms, and they were, no surprise, fatigue, brain fog, dizziness, the gastrointestinal symptoms that some people have, cardiac heart palpitations, sexual desire, performance issues, loss of smell and or taste, persistent thirst, which is one that I think
That's interesting.
is a little bit different. Yeah. Chronic cough, we've heard about, chest pain, and then abnormal limb movements. So
Abnormal what?
limb movements.
Oh, okay.
Yeah.
Like
So
spastic or?
Well, it's not specified, and I think we have heard some question about neurologic events. I mean, effects of long COVID in people. There certainly have been a few of mental health and psychotic events with long COVID as well, but not overwhelmingly not the most common types of symptoms. Yeah. The other, the American Academy of Sleep Science has reported sleep disturbances, particularly an insomnia. They're calling COVID-somnia.
Oh,
So,
interesting. Yeah.
Yeah.
And what about treatments for long COVID?
There you go.
Just right on time.
Right on time. We didn't rehearse this, you guys. Yeah. What about treatment? So there are 2 new studies. There's a bunch of new things that are being launched. Finally, we have more places, particularly in urban settings, that makes sense, of actually having clinics and providers that are focused on long COVID. And there's 2 new studies funded by the National Institutes of Health for potential therapy. One is called Recover Vital, and that's all caps -vital. And they are using Paxlovid for 25 days straight, and their
wow, for 25
population
days.
Yeah, their population that they are going to study is going to be 900 people, so they're recruiting for that. And then there's one called Recover Neuro, the same all caps for that, where they're using low-level electrical currents to the brain for those that have predominantly neurologic, probably the brain fog and neurologic symptoms.
So when somebody has long COVID, are they continuing to shed virus at high levels, or?
I don't think so.
So what's the mechanism of action for Paxlovid that they're applying? Do you know anything about that? I'm just curious.
I think they're the component of Paxlovid that addresses the over response. Long COVID is thought to be an immune response that has gotten out of control.
Right. Okay.
And so the intent is to downregulate that immune response, do it for long enough that if you interrupt it for long enough, perhaps it'll reset at its, more normal.
Have they thought about the biologics, the anti-TNF biologic?
There are a bunch of things pending, and I did
Yeah,
not look
yeah.
into those. Yeah.
I mean,
So,
I know
yep.
we're getting a little far
Yep.
afield, but I
Yeah.
was just
No, I think we're
thinking
going to
about-
start seeing some of those things show
Mhm.
up, because there's a lot of different ways you could approach this, right?
Mhm.
You
Yeah,
know, so yeah.
Hmm, interesting.
But at least those two are undergoing right now, and it seems to me, from what I've seen, that it's the NIH that is sponsoring most of the studies.
Mhm.
So I do have a cool vaccination update and it's just one topic, but it's quite fascinating to me. And I do not claim to understand exactly what they're doing. So I'll just tell you that right now. I copied the article on it because I can read parts of it if there's some questions that I didn't write down. It comes out of the University of Cambridge in the UK. And its initial work actually started before all of the vaccinations that are COVID specific were being released.
Mhm.
It is a vaccination antigen technology. It is called Diosynvax. I'll spell that. Diosynvax. And what it is, it's digitally immune optimized synthetic vaccine.
Whoa.
So I know.
Digitally,
So
wait, digitally?
digitally immune optimized synthetic vaccine. So I don't know what that really is, but that's what it's being called. And the first in-human safety trials are actually ongoing now, which is new. So let me
Who's
read.
doing that? Who's the manufacturer?
It's coming from a let me tell you, it is a company that is it is sort of sponsored, or a side company that came out of Cambridge's.
Okay, University of Cambridge. Okay, I was just
yeah.
curious. Yeah,
Yeah.
I can
There
try to
is,
look it up while you're.
yeah.
I'll try to look it up while you're.
Yeah, I have it in here
Okay.
that we can address. Okay. The research was initially funded by a UK vaccine network program, and then this Dios COVAX program, which is doing this Diosynvax.
Oh,
So
Diosynvax is actually the company.
it's the product. Let's see. Okay. It is Diosynvax, a spin-out company from the University of Cambridge, established in 2017 with the support of Cambridge Enterprise.
Mhm.
So for those, I can put the info in the chat for those.
Yeah, I'll put it in while you continue, because I
Yeah.
found it.
Yeah.
Okay.
Yeah. So really, the idea behind this is to maximize is to maximize and widen the spectrum of protection that the vaccines could give, and do it in a more global way, so that you're not having to create a new vaccine for every new variant of COVID or every new virus that comes along. We will see more viruses. They actually started looking at this approach after the SARS bird flu that came around, and that's why the work was already ongoing when COVID actually hit. So really, all of our current vaccines are like the seasonal flu and the COVID and measles, all those things are based on the viruses we have at hand. So you may have remembered in past programs, I said, in the spring, they start looking at any new variations that come along, and they incorporate a component of that in the fall antivirus vaccination that they're making. This would not make that necessary. And so what they're what they're really trying to do is get a vaccine that focuses on a common antigen area of all or most viruses, and be able to have that cover future variants that might come up as well as current. So I find this really fascinating, because then as a consumer, we'd be one vaccination in the fall, once and done,
Yeah.
or close to that. Yeah. So fascinating that they finally now have some, I mean, it's taken them,
Yeah.
7 years to get to in human trials. And some of this work started with input from the veterinary research branch in England as well, in the UK. So, yeah.
So we have 4 minutes left, and I
Yeah,
know this
so-
session has been absolutely packed, which we knew it would be.
Yes, yes.
And
Yes, yes.
so
Yeah.
if there
So
are any
yeah,
remaining
look for any
questions
other
quickly.
questions. And while you're looking for questions, I did, when I mentioned workforce and I mentioned the difference in who masks at work for healthcare workers and so on.
Mhm.
And I'm recommending that Health Advocate X really do a focused look at some of the issues that we have across the country in not having enough nurses and not having enough physicians. We're seeing a really unprecedented early retirement, people in mid-career walking away from medicine altogether. And I think that really deserves some exploration. Not that we're going to fix it, but to try to figure out how we can work in our best way with the existing healthcare providers and not get frustrated. I mean, primary care providers, I don't know, my sister's looking for one. She has to wait till December to get a new
Yeah.
primary care provider. So
we
it's a good topic for future.
will,
Yeah.
definitely look at that. So
Yeah.
That is also a public health issue.
It is a public health issue.
Yeah.
And a personal health issue.
Yeah.
Yes. Yes. You
mhm.
got some questions there, Robin? Or are we?
No, I think let's see. Want to make sure that I didn't miss anything. So just to re-emphasize what you said about what we know now about the vaccine, that it doesn't increase your risk of getting COVID or long COVID, and it doesn't increase your risk of getting other diseases. So basically,
Or dying from something else that, I mean, if you have some other disease that could potentially kill you,
the
then
data show that there's no increased
it
risk
has
from
not
taking
been,
the vaccine.
yeah, has not.
We haven't seen that risk.
Yeah.
So I think that's just important to re-emphasize. We had a question about that. This was packed full. Thank you so much for doing the preparation to kind of winnow it down to a digestible 1-hour format. So thank you so much for coming back to do that. And I know it won't be the last time that we see you here, because you've said that you would maybe do this a little later in the year as well, when it's appropriate. Before we sign off, I know we just have 1 minute. We have a lot of events happening in May, and I wanted to make sure that people had them on their calendar. On May 6th, we have the movie Angst, and we are doing a live virtual screening party, and it's a not to miss movie event. We always do one in the spring. We'll have a really interesting panel discussion around that. And, everyone who deals with anything in life knows that mental health is just an essential thing, essential competency in navigating life for yourself, clients, family members. So don't miss that, May 6th at 4 p.m. And then our next community conversation will be on May 13th with Adrienne Miller, and it's respite or permanent move, adult family home, assisted living, or memory care. Where do we start? And so we're thankful to Health Advocate X Adrienne Miller. She's a member navigating the transition to adult family homes, assisted living, and making those transitions. So you don't want to miss that. That'll be on the 13th. And then also on the 16th of May, we have a case review at 5 p.m. and that will be Sarah Jane Yang, who's going to be talking about reducing financial barriers in healthcare. And so very important from a health advocate professional perspective. And we are changing our case review format. So I wanted to make sure everybody knew about that. We are opening it up to non-members alike, which means that it costs more money if you're not a member, but it's free for Health Advocate X members. There's a minor cost, $15 if you want to get a CE. And if you're a non-member of Health Advocate X, I think it's $40. So that is now on our website and ready for you to register. And we hope to see you at one of our events. Thank you, everybody, for joining us. Thank you again, Dale. Really appreciate it. And
Yeah.
we'll see you soon.
Good to
Bye,
see
everybody.
everybody. Yeah, bye.
Bye, everyone.